Hello, good morning, good afternoon, and good evening, everyone. And we would like to welcome you to our Module 3 of the Neonatal Nursing Course. And today we're going to be talking about the respiratory system of the neonates with a focus on the preterm infants. And the respiratory system webinars are split in two parts. So today we're going to be covering the basics of the respiration system of the neonates, and in the lecture on June 9th, we're going to be covering the basics of mechanical ventilation. So again, my name is Margarita Singer, and I am the Regional Marketing Manager for Neonatal Care at Dräger. And today I will be doing a demonstration on some of the ventilatory support systems that we have at Dräger, and here in particular I have the Bubble CPAP system. But most importantly, we have Ms. Linda Pretorius as our esteemed guest speaker, who will be delivering the lecture today on the basics of the respiratory system of the neonates, and also providing the insights into the lung injuries, into the impacts of the mechanical ventilation, and also we'll be covering the basics of the mechanical ventilation, such as oxygen therapy and non-invasive ventilation. So again, if you have any questions, we have the question box, so please type them into the question box. We're going to have 2 breaks, and we're going to be covering the questions in the 2 break sessions. So without ado delay, I would like to give words to Linda, who will be recapping the past 2 modules, and of course sharing the respiratory system of the neonates.
Thank you, Margarita. Thank you, Margarita. I hope everybody can hear me, and welcome to everybody after our break. It really has been nice to get some comments from you. Thank you for the emails I've received. And let's start and go ahead. So where are you all watching from? I have put down all the countries that we've had responses from down here for you to all see. I added it up, and it's 40 countries that have been watching us. And thank you very much for all being part of this webinar. So I think what we're going to do now is just deal with the recap of the situation, so that we can just see where we are. I'm just trying to. So let's start with the top 10 take-home messages for neonatal life support. Last time we did resuscitation. So newborn resuscitation requires anticipation, preparation by the providers who train individually as well as the teams. This is very important, guys, and I hope that that message was not only driven home by myself, but by the lecture of Dr. Paul Clark and Dr. Cowley. Most newborn babies do not require immediate cord clamping or resuscitation and can be evaluated and monitored during skin-to-skin. Inflation and ventilation of the lungs are the priority of the newborn baby, and I think that's the main drive home, as well as dealing with it in a calm, careful, and caring manner. A rise in the heart rate is the most important indicator of effective ventilation and response to resuscitative efforts. Pulse oximetry is used to guide the oxygen therapy, and this is very, very important. I just want, sorry. Chest compressions are provided if there's a poor heart rate response to ventilation after appropriate correction steps have been taken, and preferably there's a bit of intubation. The heart rate response to chest compressions and medication should be monitored. If the response to chest compressions is poor, You can give epinephrine, or what we call adrenaline in South Africa. Failure to respond to it in the baby, or a history of constant blood loss. Look at volume expansion. And if all the other steps are effectively completed and there's no heart rate after 20 minutes, then there must be a rediscussion. And this comes from the latest American Heart Association, their magazine called Circulation, and this was from their October edition, and you can see it there. You can go back and see it. There is the algorithm. It hasn't changed much, so actually not at all. So that algorithm is still appropriate, and I've loaded the app for you from that is from the American Association of Pediatrics, which has the whole algorithm plus the drugs in it for those of you who would like to have the app on your phone. And this might be a suggestion to people who don't work all the time within that area. A new article was published at the end of April. The article is on PubMed, and the title is The Effect of Two Different Chest Compression Techniques on Ventilation During Resuscitation, done by Joanna Jensen out of Norway. And what they have found is that in actual fact, the two-finger method and not the two-thumb method is more appropriate. There is a better chest compression there. So those of you who want to look at that, that article is available. So let's just recap, because one of the biggest issues that we find with regards to neonatal resuscitation is that when the babies start losing their heat fast, they don't respond to resuscitation as they should. So let's just run through the 4 ways they lose their heat: through conduction. So putting them on a cold surface is a problem. Evaporation, so the radiant heaters can be a problem there. Convection and radiation. All of these very, very important to remember to get that baby and keep that baby as wrapped as possible. And this is very often a nursing task because the doctors forget. You've got to say in the resus, keep wrapping the baby. Then the other problems that we have is the positioning of the baby. And I've put these pictures, these illustrations there for you. If the baby is not in the correct position, or what we refer to as sniffing the morning breeze position, and the airway collapses or there's over distension of the airway, you are not going to get decent infiltration into that lung of the oxygen. Please remember that, because that is the biggest part of the newborn resus, is to actually get the ventilation going in the lung. So the position is very important. You can see in the top, in this top drawing here, that they've put this towel under the baby's shoulders, and that gives you the correct positioning. It's very important that in preparation you have that towel ready. Here you can see how the airways collapsed, and this one you can see how the airways over distended, and you won't get decent aeration there either. The other big problem is the mask positioning of it. We talk about the mask needing to be on the glabella of the nose, which is just here. If it is too small a mask, it becomes problematic. If it's too big a mask, it becomes problematic, because we will have air leaks either way, or inefficient expansion of the lung. Please remember that babies are obligatory nose breathers. And because they're obligatory nose breathers, it's important that the mask go over the nose. And then just for those of you who haven't seen Module 1, I have put the link there for you, as well as Module 2. They are both now available on YouTube for you to see, and you can go and view them on YouTube. And then by the end of next week, we will have loaded Dr. Paul Clark and Dr. Paul Cowley's lecture, lectures with regards to the delivery room cuddle and the golden hour. These 2 lectures slot in very nicely into the first 2 modules, and they also we will also use them for today's lecture so that you can see exactly how this all starts playing together. So let's start on the respiratory system. And I think we need to start looking at what the developmental or the embryology is of the lung bud initially. So just to give you a breakdown here, the actual respiratory system originates out of the mesoderm layer of the egg sac and the actual fetus that is starting to develop. It doesn't carry out its function until birth, and this, however, becomes a problem because as we go through these, you will see that the lung at 24 weeks is not very mature. So that lung is not fully formed, and that's what we're trying to get gaseous exchange from. However, there are muscular movements which are seen very early on already. The lung isn't aerated, but there is movement of muscle, and this allows for the development of the muscles and the diaphragm, which will be developing at that stage. The respiratory tract develops in 2 parts, and it occurs early in pregnancy. So the upper respiratory system, which consists of the nose, the nasal cavity, and the pharynx, and the lower respiratory system develops with regards to the larynx, the trachea, the bronchi, and the lungs. Another important part of the development, which does occur early on, is the development of the diaphragm. The diaphragm develops from the spine forward, and if you have something like a hypoplastic left lung, or where you have a diaphragmatic hernia, so the intestines protruding up through the diaphragm into the chest, this will prevent the lung on the side where the intestines are from developing fully. And this problem originates from the fact of the matter is that the diaphragm comes from the back, from the spine, and grows forward. And sometimes if the intestines are in the way, the diaphragm doesn't form, and so the intestines go into the chest, and they then lie up against what we call the lung bud, and that prevents the lung from developing fully. In late fetal development, the thyroid hormone, respiratory motions, and amniotic fluid, which has been swallowed by the baby, will allow for the maturation of lungs. But this only happens from about 32 weeks onwards. The respiratory system is only completely formed by week 24. So both the respiratory movements and amniotic fluid help with the growth. So the fetal lung volumes at a week 12 to 13 is about 0.05 mils. So that's 0.05 mils. At 19 to 20 weeks, the lung now can take half a mil, and from 29 to 30 weeks, the lung can accommodate about 1.9 mils of that's the volume it takes. This is very, very important because very often, once a baby is born and is resuscitated, the resuscitation is very vigorous. And the vigorousness of this resuscitation will actually damage the lungs immediately. There will be barotrauma immediately, and that becomes problematic. Surfactants are the compound which reduce the resistance between a gas and a liquid and allows for the exchange, gaseous exchange. Surfactant, it starts being present in the lung from about 24 weeks. However, it is very often not the right component or the right volume. It improves the lung compliance. What that means is that it allows that little alveoli to stretch and relax without any problems. It recruits collapsed alveoli. It keeps it open. It's almost like soap bubbles. It allows the lung to stay open, and it prevents atelectasis at the end of expiration. And this is very important. Now, if we were to look at this picture, what I do need you to keep considering is that this is the alveoli. This here is the capillary bed. And the interchange happens when there's sufficient air movement in here and the alveoli is wide enough on this capillary bed. So if the blood pressure is low, you're not going to get gaseous exchange. If the blood pressure is too high, you're not going to get decent gaseous exchange. If you're not getting enough air in, or you're putting in too much air, once again, you will flatten this capillary bed and you won't get gaseous exchange. So the whole idea with respiration and resuscitation is to have this perfect balance so that O2 can move from the alveoli into the blood vessel, and that the CO2 can come from the capillary bed out via the alveoli. Surfactant, it prevents fluid buildup, or what we call wet lung. So if we don't have sufficient surfactant here, we'll start seeing injury or shearing injuries here, and that in itself will become problematic. Vitamin D stimulates alveoli type 2 cells, fibroblast proliferation, as well as surfactant synthesis and alveolization. And currently, we are starting to see quite a few articles coming out saying that low vitamin D levels in the mother will cause respiratory problems in the infant. It doesn't mean that if we were to, that there's not a correlation saying that if we supplement the baby's vitamin D, we will see an improved lung function. However, that we need to get to the point where we are testing mothers to make sure that their vitamin D levels are acceptable. Surfactant, as I said, starts being produced at about week 24 and is present in the amniotic fluid by week 28. So many years ago, they used to do a surfactant test by aspirating a bit of amniotic fluid and looking at what the surfactant levels were. That doesn't seem to be a trend at the moment, but things change. You know, every 10 years something else comes in, and then at year 20 we start seeing them do it again. But at the moment it is not in vogue. Fetal circulation. So last month we looked at fetal circulation, and I'm just basically going to recap it. So the oxygen comes via the mother's uterine arteries, and the placenta here acts almost like a kidney, in that there's diffusion of oxygen across, it gets taken up, and it then moves across to the baby, into the baby. Do remember that last time we spoke that the umbilical vein carries the oxygen and the waste gets carried away by the umbilical arteries. In the fetus, the oxygenated blood comes via the umbilical vein, and most of the oxygenated blood will enter the right atrium. This means that in utero, oxygen saturation levels are very different from the upper and lower bodies. So if there is a cardiac lesion or there is a diaphragmatic hernia, it does not affect the fetus till the minute the baby is born. Fetal circulation is characterized by low systemic resistance and high systemic blood flow. So there's very little resistance and there's blood flow. At birth, we come back to this whole idea of the patent ductus arteriosus. Remember that when the baby's born and the first breath is given, the pressure in the lungs increase, and that will initially stop the shunt from happening. As the shunt stops happening, this will now become smaller and attendant, and we did discuss that last time. With the clamping of the cord, there's a loss of blood flow from the placenta. The systemic vascular resistance rises, increasing the pressure into the left atrium, which is over here. The lungs expand and pulmonary resistance falls. Flow now follows the normal path. The PDA as well as the ovale will close. So basically, and it's not an immediate closure. The closure is a physiological closure over a period of time. So it's very important that we give the baby that time to transition. And very often I think that we tend to chase numbers and not allow the baby to make the transition. Cardiac output is now about 500 mils a minute. Remember that the circulatory volume to this baby is only about 80 mils per kilogram. So if there has been a bleed, and we're going back now to what we recapped, and there has been an umbilical or umbilical cord tear, or the baby, or there was a placenta, an APH, so an antepartum hemorrhage, we've got to consider that the baby's blood flow has been reduced, and we might need to give volume to actually get the resuscitation going. It is very important that if we can do delayed cord clamping, it would be great, because the return to the fetus or the baby at that stage is quite a big volume. It can be up to 80 to 100 mils. In a term baby, in preemies it will be less, but it will help the baby considerably. All babies are born acidotic. Please remember this, because very often doctors and nurses do blood gases, and that they want to do and make adjustments, and they don't allow the baby to get through the transition. Fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin, and on the sort of very sophisticated blood gas machines, it will show you what your fetal hemoglobin is. The oxygen delivered to the lung supports its growth and metabolic function. So the oxygen, just as the oxygen that goes to the heart also supports the heart, it supports the lung. It's very important that we remember that. Now let's talk about neonatal anatomy, because very, very often this is where we lose the plot, and we think that it is actually another problem, and in actual fact we're just not allowing the anatomy to do its job. As I have said to you before, neonates are obligatory nose breathers. So if there is a blockage in the nose, like a choanal atresia, that baby will battle to breathe. And babies don't automatically open their mouths to breathe. You actually have to have open the mouth to breathe. So that's very, very important to remember. Also remembering that the younger the baby, the more incomplete the entire airway will be, and that will contribute to its collapsibility, meaning that it will collapse. Remember that the airway or the respiratory system sits on top of the GIT system. So for the two systems to work together, the upper respiratory system, so from the epiglottis just past to the larynx, that whole part past the trachea, that part has what we call C rings, meaning that the cartilage there is in the formation of a C, and that's a very important thing to remember, because what it means is that the esophagus sits behind that airway. And if there's something large in the esophagus, and I'm sure many of you have had this, you've swallowed a big piece of potato or meat or whatever you eat, and it feels like it's stuck. what happens is that esophagus pushes into the trachea part of it, into that upper airway, and you feel it move there. And those C rings in prem babies and very often in term babies are immature and very soft. They're not a full cartilage yet. And so the collapsibility of it actually happens quite easily. So you can see in this drawing here how it happens. And just as I've said, and if you look at what they've done with this baby, when you turn the baby prone, that airway stays more open. And we will talk about this proning later on in the lecture. Here again, you can see, remember that one of the problems with a neonate is that their tongue is quite large for their mouth. And the reason for this is not actually the large tongue, it's the shortened jawline here. So they have this protruding jawline. And that is what allows the tongue to land on the in the airway here. So by lifting it, as I showed you earlier, you will just lift that tongue off the airway. The other thing to remember is what is happening to the alveoli. And this is often where, as nurses, we make big mistakes, is that we don't realize what it looks like. It actually looks almost like a bunch of grapes, and some grapes are inflated and some are collapsed and some are overinflated. So this is what it actually looks like. So hypertension and dehydration will affect the blood flow to this. Overextension or vigorous bagging will overextend the alveoli and perhaps cause tears, but the other problem that occurs is that it will flatten this capillary bed and gaseous exchange is difficult. Therefore, hemodynamic monitoring is absolutely essential. So when we look at gaseous exchange, fetal respiratory movements are regular muscle contractions which are present from the 3rd term. They prepare the baby for breathing. So they've got to get those little intercostal muscles working and working, developing. Up until birth, the lung epithelium has a secretory function, and only after birth does it become an absorption function. Once again, this is part of transition. This exchange from lung fluid for air leads to a decrease in pulmonary resistance, an increase in pulmonary blood flow, a thinning of the pulmonary arteries due to the size of the lungs increasing and blood rushing into the system. Guys, it's very important that when you look at children or preemies with or term babies with TTN, transient tachypnea of the newborn, often what you see is that they are bubbling, that there's this fluid coming out of their noses. And this is because the lung hasn't emptied sufficiently, because it very often happens mostly in cesarean section babies, because the pressure hasn't happened during the birth canal to empty out that fluid that is in the lung. So the idea of this lung that is almost fluid locked, and then there has to be this transition moving the fluid out and allowing for the gaseous exchange to happen. So how does gaseous exchange happen? We've spoken about this. So in the capillary bed, what you're seeing here is these purpley spots or circles contain CO2. So the CO2 gets exchanged out and the O2 gets exchanged in. And this will come from, and this will go to. So the airflow happens in, and there's a very thin membrane here, and gaseous exchange happens. So alveoli are required for gaseous exchange. The alveoli have 2 types of cells, which both occur really around 24 weeks of gestation. And for successful gaseous exchange, we need the alveoli, the diaphragm, pulmonary circulation, and surfactant. If one of these 4 are missing, we are not going to have good gaseous exchange, and the baby will become progressively more respiratory distressed. Pulmonary resistance. Pulmonary vascular resistance is the resistance of the pulmonary circulation against the systemic system. So in utero, we have high pulmonary vascular resistance because the lungs aren't expanded and they are now fluid full. The lungs in utero have a low systemic blood flow, okay? So there is very little blood there, that shunt that we talk about, and the preferential blood flow to the heart and the brain is happening now from the placenta. This is very important. Once again, we come back to preductal and postductal. Pulmonary blood flow to the lungs in the human is about 11%, increasing to about 25% of cardiac output by 30 weeks. So it progressively gets more and more, and that's why it is so important that when we're dealing with the microprems, we are careful with the way we resuscitate and the way we deal with their lung fields. The pulmonary vascular resistance remains high as the lungs aren't opening and the volume of blood to the lungs has been restricted. This happens until that first breath happens and we get the change. Baby can remain in fetal circulation if it's significant or if there's respiratory distress syndrome is progressing. We mostly see this fetal circulation persisting in large babies with meconium aspiration. We do not tend to see this sort of what is known as pulmonary hypertension of the newborn. The old system we spoke about, persistent fetal circulation or PFC, is mainly in the big babies. The prem babies generally present with a left to right shunt, which is not really problematic. Let's talk about lung compliance. So lung compliance is the ability of the lung and the thorax to expand. Remember that the lung is attached to the thorax. So by then pushing, breathing in and the thorax expanding outwards and downwards with the diaphragm, we now get the air in, the alveoli is expanding, and what happens is then we get gaseous exchange. If there's an error somewhere in there, it's problematic. So if ribs have been broken, we're not going to get decent inhalation. If there's a hole in the diaphragm and we've got an intestine sitting here, we are also not going to get decent expansion. And so we must remember this. Or if there's problem with the lung per se, so for instance, we have a pneumothorax, we're not going to get this decent expansion that is necessary. Good expansion reduces the working of breathing. So if there's decent expansion and all the alveoli are working, then the workload is not there. But if these alveoli keep collapsing or become atelectic, then what happens is that the baby, every time it breathes, it's as hard as the first breath it had to give right in the beginning. If there's good lung compliance, we reduce energy usage. And this is very, very important because weight loss initially could be due to the workload, just working and breathing hard. Magnesium directly influences lung function as it stimulates smooth muscle usage. And this is a very important concept. And we will cover it later. Colostrum contains large volumes of magnesium. So early feeding has shown to also be of benefit. So how do we identify the respiratory distressed infant? And what I need to talk to you here about is that you remember that respiratory distress can be a symptom of a problem. We do have something called respiratory distress syndrome, which in babies is considered a lack of surfactant, but a baby that is respiratory distressed does not necessarily have RDS, or respiratory distress syndrome. There may be another reason to it. So respiratory distress will affect up to about 7% of all babies born. Fast action is not only identifying, but treating these babies is important to prevent the burden of disease. And while we're here, one of the biggest problems with regards to resuscitation and looking after these babies in the beginning is maintaining the neutral thermal environment. Once again, if you look at this picture, we have a problem. This is not an acceptable method of maintaining this because there's no reflector here, and so the radiant heater will not give this baby the set temperature you have dialed in. That in itself, once again, can worsen the respiratory distress because a cold baby or an overheated baby gets dehydrated quickly and breathes faster. So now you're increasing the workload. There could be short and long-term complications such as chronic lung disease or BPD, bronchopulmonary dysplasia, which is basically baby COPD, respiratory failure and failure to thrive and death. The failure to thrive comes because these babies actually cannot maintain the energy, or they cannot take in sufficient energy to maintain their workload of breathing. The problem with respiratory distressed babies is twofold. One is reserve and the other one is pulmonary vascular resistance. So let's look at how do we identify this baby. Firstly, it could be tachypneic, or if it's been breathing for far too long with tachypnea, it will go towards apnea because it's now progressive, and you get tachypnea and then you start seeing apnea, and then you finally see apnea, small bouts of apnea, and then finally you have end apnea, which just you're not going to get anywhere with that. With the tachypnea, you will see a tachycardia as well. You may see cyanosis. You will see nasal flaring. You'll hear this grunting. Very often the older nurses and doctors refer to it as pushing PEEP. They go, We will see apnea or dyspnea. Dyspnea is they start using accessory muscles, and as it says here, chest wall recessions, suprasternal, intercostal, and subcostal. So these babies present with tachypnea and or apnea, tachycardia. They have low saturations, so the reading is below 85 or thereabouts. They are cyanotic. They can be centrally or peripherally cyanosis, or both. The blood gas is poor. There is rib recession, retraction, and this grunting. So what does the respiratory distressed infant, what should we be looking at? What could the causes be? It could be transient tachypnea of the newborn. That will go away as the fluid out of the lung disappears and is absorbed. The respiration improves. There could be a respiratory distress syndrome because it's premature. It didn't receive its antenatal corticosteroids. There may be the actual prematurity may be a problem, so that can be there. There could be meconium aspiration syndrome. There could be a pneumonia. Babies are very often born with a pneumonia. There could be generalized sepsis. The delayed transitions could be a big problem, or Generally in the bigger babies and larger babies, so infants of a diabetic with meconium aspiration, we will see persistent pulmonary hypertension of the newborn. What do we need to exclude? So check the airway. Is there a co-anal atresia or an upper airway collapse? So if we've got something like tracheal malaria, where the C rings are just collapsing and the baby actually is going to require intubation and or trache. Are there cardiovascular problems? Are there cardiac lesions that are problematic? Is there thoracically a problem, such as a diaphragmatic hernia? Are there neuromuscular problems, such as torch infections, toxoplasmosis, others, rubella, CMV, and herpes infections in the pregnancy? Or is there a large intraventricular hemorrhage because the resuscitation initially was a long resuscitation or a vigorous one? Remember that the research is showing us intraventricular hemorrhages mostly happen in the first 24 to 48 hours of birth. And then other problems such as sepsis, hypoglycemia, anemia, and hypothermia. So, if we look at the respiratory distressed baby, what is the problem? If we look at this top one, this is as it should be. So the alveolus has expanded as it should be. The blood flow from the heart to the lungs is happening, and the blood flow away is happening, and the pressures are correct. That's how it should be. In respiratory distress syndrome, blood passes by underinflated alveoli because we don't have that surfactant to allow it to expand, and we don't get oxygenation. So this is a question of never the two shall meet. The alveoli is up here, and here is the circulation, and we can't have gaseous exchange. In pulmonary hypotension, what we are seeing here is that there's very little blood flow coming in, and so the gaseous exchange is not going to happen properly. Interstitial edema or transient tachypnea. So if there's interstitial edema sitting here, once again, never the two shall meet because it will interfere with the oxygenation. Alveoli edema or debris, so some problem here. Once again, we are going to battle to get this expansion. And so the alveoli interferes with the oxygen gaseous exchange. Right, let's talk about reserve. Every baby has reserve. Most babies have a very small reserve. What does reserve mean? It's the period of time that baby has that it can try and cope in that situation. If you do not help that baby quick enough in that period of time, the reserve will run out and the baby will crash. So very often we don't consider what the reserve is. So the reserve is when a patient is compensating, and if we leave the situation as it is, the baby or the patient will deteriorate and collapse. Pulmonary vascular resistance, due to the elasticity of the baby's chest wall, the newborn baby is prone to atelectasis and lung collapse. And this is further complicated by the pulmonary vasculature not acting as it should, and the respiratory system becomes worse. So if we look here, prenatally, birth asphyxia, meconium aspiration or infections, that will give changes in the structure to pulmonary vascular situation. The pulmonary constriction increases. There's an increased right heart pressure, and a right to left shunt happens. When we look on this side neonatally, meconium aspiration, RDS, sepsis and pneumonia, once again we get this. vasoconstriction that occurs with alveoli hypoxia. There's increased right heart pressure. There's increased right to left shunting. There's hypoxemia, hypercapnia, and acidemia, and it just goes in this vicious circle. So somewhere here, we've got to start intervening. We've got to prevent it from getting worse. Oxygen toxic effects. Supplemental oxygen in premature infants contributes to the development of BPD, or chronic lung disease. And this is characterized by dysregulated inflammation and altered expression of the growth factors. And this can result in fibrosis, asymmetric aeration, and respiratory insufficiency. And this comes from an article from Science Direct. So what actually happens if we overuse oxygen? We get ROP, so blindness. We get damage to the developing brain, or CP. There's DNA changes, which could lead to cancer. There's an insulin or endocrine problem. So they get raised glucose, and we stress these babies out. There's renal problems. There's early aging. There's alveoli collapse and atelectasis. There's a prolonged hospital stay. There's reduced myocardial contractility, and there's bronchoplastic dysplasia. And this is very important. This one, IVH, because that will be what it will cause. That's the third one. Then we'll see NEC, and the other prolonged hospital stay is what is tracked via the VON data generally. So it's very, very important that we know how dangerous oxygen really can be. Oxygen is a drug, and it needs to be given properly, because in large quantities it can do damage. We do need to wean that oxygen as quickly as we can. It's best to start with least invasive, so nasal cannula, and move your way up to a ventilator. The doctors I've worked with always says you have to earn your ventilator. So this means we should look at nasal cannula, high flow cannula, CPAP, conventional ventilation, and finally oscillation. The latest NICE guidelines now show that oxygenation in the unit should be 88 to 94. We should not allow that saturation to go above 94. Just keep it where it is. It's very, very important that we administer oxygen correctly. So when we look at using nasal cannula can deliver oxygen via low flow, medium flow, or high flow. It's the least invasive, but it does need to be humidified. And this is very important. Dry oxygen is not good in these tiny nasal passages. It's the least causing of gastric distension, and it allows for this baby to go skin to skin. So if we can get away with nasal cannula, yes, we should do it and allow it to happen. In a recent Cochrane review, this is in 2016, and I'm going to quote, high flow nasal cannula has similar rates of efficacy to other forms of non-invasive respiratory support in premature infants for preventing treatment failure, death, and chronic lung disease. Most evidence is available for the use of high flow nasal cannula as a post-extubation support. Following extubation, high flow nasal cannula is associated with less nasal trauma and may be associated with reduced pneumothorax compared to nasal CPAP. Further, adequately powered randomized controlled trials, RCTs, should be undertaken in premature infants comparing high flow nasal cannula with other forms of primary nasal with other forms of primary non-invasive support after birth and for weaning from non-invasive support. Often we are negligent here of weaning the cannula quite quickly. Further evidence is also required for evaluating the safety and efficacy of high flow nasal cannula in extreme preemies and mild premature subgroups, and for comparing different high flow nasal cannula devices. And that comes from the Cochrane review. So now we can go into questions, if that's okay.
Perfect, Linda. Thank you so much for this excellent presentation. I think we've learned a lot about the basics of the respiratory system of the neonates, and also we started to talk about the pathophysiology of the lung injuries in the neonates. So now we are open to take your questions. So if you do have any questions, please type them into the question box, and we will address them in the next 10 to 15 minutes. We have one question that came in earlier in the webinar, and the question is the use of comb-fill necessary to get a good seal on the CPAP, or can it be used without it? Linda, I don't know if you're comb-fill, yes.
Margarita, comb-fill works well. It's not just about the seal, it's about reducing the pressure. But very often the problem with the CPAP masks are that they're not soft enough and they don't seal properly if the systems are problematic, meaning that the mask is quite a hard mask, and then you really do need comb-fill to protect that baby. But if you look at something like the circuit that comes with the Seattle PAP, that circuit you don't really need comb-fill because it's a very soft circuit, and it really doesn't do as harm to the baby. Also, the important thing is that every time you work with that baby, you actually loosen the mask, change it, look at it, and ensure that there aren't any pressure areas under it.
Excellent, thank you, Linda. Okay, so far we haven't had any further questions. For those of you who have questions, please use the question box to type them in. Or otherwise, okay, perfect. There's a new question come in. So yeah, type your questions into the question box, and we will have a break now, and we will also have another break at the end of Linda's lecture to cover the question. So there's a new question that came in, which is quite interesting. Is there a possibility of leaking when intubating?
Yes, because leaking. Well, most hospitals still today don't use a cuffed tube. So there is leaking that occurs past if you're using too small a tube, which is probably the way to have an error. There is leakage that will occur there. Definitely it will occur.
Okay. So far, I have not seen any further questions. I think, Linda, your explanation is just excellent. We doesn't leave any questions. So, yes.
Margarita, just on that, on the leak, I think I do need to make a point that there was a recent study that showed that a baby, most babies and most preemies will desaturate within 54 seconds of you stopping the BVM or bagging, the so-called bagging of the baby. to the point where it's below 80 and you need to rebag the baby before you reattempt intubation. And I think this is often where a lot of distress and a lot of damage happens, is that people trying to intubate take longer than they should, so the baby uses up its reserve. But the other thing is then that when we go back onto the BVM or trying to bag the baby, what we see is that we then do it quite vigorously because now the saturations are very low. And that is where we see a lot of barrow trauma, shearing trauma, that sort of thing happening. So in the resuscitation and when intubating, it's very important that we count it down and tell the doctor. But be careful with the way that you carry it across, because if you sound distressed, they will get distressed. So just say, we're down to 90, we're down to 85, we're getting to 80, can we restart? Just so that that doesn't happen, because I think more importantly than a leak, that's where we see damage happening.
Excellent. Thank you for further explanation on this, Linda. We had a few more questions coming in while you were doing the explanation. So the next one, please, you talked about giving the baby time after birth to allow for extrauterine life adjustment. How long do you wait then for full adjustments?
So this starts to look like, and I'm not going to say it is, but it would appear that there's a lot more to play than just doing it. Now, if you go back to module 2 and you look at resuscitation, you will see that you actually have 10 minutes to get that APGAR up and give initial transition to happen. Then, and when we finished, when the break's over, we're going to talk about the LISA method or other methods which help. And that will help with the transition as well. And then returning the baby skin to skin. So those of you who attended Dr. Paul's lecture, the whole fact that the baby returns back to the mother and allows for a certain amount of oxytocin to be released will help regulate that baby. So as long as we get the surfactant in quick enough, we should give that baby at least 15 to 20 to 30 minutes chance to get to allow the surfactant to diffuse and allow it to happen. This transition can take a few hours, and we need to just leave the baby. The biggest mistake is that everybody touches and fiddles. And when they touch and fiddle, the baby goes into a flight and fright reaction and it battles to adjust. And so we're increasing its workload of breathing there.
Perfect. Thank you so much, Linda, for this further details. There's another question that came in just a few moments ago. Can you please explain the physiology of PDA and alveolar physiology when to give surfactants?
Can you repeat that, Marguerite?
Can you please explain the physiology of PDA and the physiology when to give the surfactant? Basically, what are the indications when you administer the surfactants?
Okay, so we will be covering when we give the surfactant. Years ago, surfactant was, well, it's still a very expensive commodity. And surfactant was given as for what we call rescue therapy. The studies now have bore it out that giving surfactant earlier, so more preventative medication, as a preventative medication, reduces hospital stay because obviously we have less lung trauma. And so giving it earlier rather than later is far more preferred. However, what you must remember is that the minute that you've administered the surfactant and you have very often turned the baby prone, you suddenly open up the lung. And what you will then see is a drop in blood pressure because now the circulatory volume, the circulatory area of that baby has increased dramatically and quickly. And so there's this transient drop in blood pressure, and very often it will fix itself, it will self-correct. Occasionally, they may need a little bit of fluid, but it is not that common anymore. The baby compensates for it because remember that the lung feels as it opens up is quite a large volume of blood that then suddenly goes through the lung, and so there will be a transient blood pressure drop.
Perfect. Thank you so much, Linda, for this excellent explanation on the administration of surfactants. We don't have any more questions at the moment. So what I would like to propose, we're going to have a 5-minute break.
So now we are going to look at respiratory distress syndrome. And basically, this is the neonatal form of RDS, ARDS. So we get adult respiratory distress syndrome and we get neonatal distress syndrome. The big thing is that later on, in pediatrics, we do see ARDS, not the neonatal respiratory syndrome. So this is a disease of the newborn, especially of the microprem and the preemie, but it doesn't mean that the term baby doesn't get it. They do actually present with it. And we have to be very careful with these babies when we look at it. It has this typical ground glass appearance, which is very important. It is always bilateral. You don't see it just on one side, where with a pneumonia, you will often only see it on one side. So please be aware of that. Also, the infant of a diabetic, even if it is a term baby, has a much higher risk because they don't produce sufficient surfactant as a term baby, and they will present, or they can present, with RDS. A septic baby, a shocked baby, any of those babies will also present with RDS. And the lungs have this inability to produce sufficient surfactant in the right quantities. And this is important. We talk about surfactant as being A and B, and it's often the beta part that is missing when we're dealing with these babies. It will affect about 1 to 1.5% of all babies born. Respiratory distress syndrome can be prevented by giving steroids to the mother, or sometimes if there has been quite a bit of stress involved, the babies probably will do okay. But it is important that we get those antenatal steroids in. The jury is definitely out with regards to giving the baby steroids when it is born, and definitely they should not be receiving steroids at this stage, according to the Cochrane review, before 24 hours. The problem is that the steroids given to the baby can have an effect on the brain. It is the leading cause of death in the preemie group. Under 28 days is respiratory distress or progressive respiratory distress syndrome. And about 12 to 15% of babies worldwide are born premature. There has been a trend towards it going up at the moment in the lower socioeconomic or the lower income countries, such as those in Africa and Asia. And the reason for this is with regards to COVID, that income has reduced rapidly. And so malnourishment has occurred in a lot of pregnancies, and that can bring on prematurity. So what does respiratory distress syndrome look like? Here you've got the 4 grades on the left side. is grade 1. So you can see the heart borders, you can see the diaphragm, and it's basically just starting to look like the reference of ground glass appearance. In the second X-ray, you can see that we are now starting to see a few things. The diaphragm's more flattened. There's more of a ground glass appearance, and this heart is enlarging. If you look at the third one, we now start to really have to look for the borders, and that's important. And in the fourth one, you can see that we hardly can notice the heart or diaphragm, and you can see those air bronchograms. Grade 4 respiratory distress syndrome is really very bad, because long term it could lead to death, but it also could lead to chronic lung disease, or as we've referred to it as BPD. So what happens? Without surfactant, the alveoli collapse, and this makes breathing or respiration progressively worse. Gaseous exchange can't happen, and the PCO2 starts stacking. So every blood gas you do, the PCO2 is going up and up and up and up. And despite you making ventilatory changes, or you're going from nasal cannula to CPAP, from CPAP to ventilation, and you end up with these children almost probably possibly needing oscillation, that jury too at the moment is quite debatable. So the baby grunts and the baby attempts to actually cope. And this collapsing of the alveoli is the biggest problem. So what causes respiratory distress syndrome? So the maternal risks will be a previous preemie. Please also be aware there's a few articles that have recently been published talking about preemies have preemies. So a mother who's had a previous preemie can have another one, as well as that it is now starting to be documented that very often preemies, parents were preemies. Periodontal disease, malnourishment, as we've spoken about it, poverty, and being a minority group. This definitely happens. The fetal risk, being a male, having a previous sibling as a preemie, cesarean section, because there hasn't been that pressure to the thoracic cage, allowing the fluid to come out. Perinatal asphyxia, so here we're talking about an antepartum hemorrhage, a peripartum hemorrhage, and a postpartum hemorrhage. All of three of those can cause it, as well as placental problems that can all cause it. And then, of course, the mother with diabetes, as well as a mother that is septic. Respiratory distress syndrome, nutrition is very important for lung maturations. And this is very important. The mother's protein intake, as well as you've heard me tell you about the vitamin D, all of these and all are play a very important role in the development of the lung and preventing worsening RDS. So low vitamin A and D, as well as low protein, there's a very likelihood of respiratory distress syndrome developing. It is worsened by hypothermia, acidosis, and asphyxia. So when initially we were taught about surfactant and the production of surfactant, the body takes about a 6 to 12 hour period to start producing surfactant. And so by at least 24 hours, the baby should start producing its own surfactant. Acidosis, hypothermia will lead to acidosis. Acidosis can lead to asphyxia. So it's not just being acidotic, there are other components to it as well. So you could be acidotic because there isn't surfactant, But the hypothermia could worsen the acidosis because we haven't been careful in the resuscitation. So how does it progress? There's worsening lung and generalized, there's worsening lung compliance, and there's generalized edema as well. So there will be lung edema, and there could be generalized edema because of us giving fluids, trying to catch up. There's a decreased muscle tone, which comes with fatigue. There's cyanosis. There's an inability to maintain their temperatures. Remember that newborn babies or neonatal babies, so up to 28 days of life, actually don't develop pyrexia. They become cold, so their temperatures drop. Tachycardia initially, if the reserve is up and the baby is becoming end-stage shocked, they will become bradycardic. The same with tachypnea. They can end up being apnea. They'll start with the odd apnea, and the apnea will just worsen and worsen and worsen. Grunting and nasal flaring. So how do we prevent RDS? We now talk about preventative surfactant and not rescue surfactant. And we can start CPAP. Positioning is quite important. Fluids feeding and colostrum is important. And we will do a septic screen and give antibiotics. Antibiotics is debatable, but most doctors do give antibiotics. So we're back to surfactant. Surfactant reduces the surface tension and facilitates easier gaseous exchange. Now, in RDS, we often see RDS in trauma, and we are now seeing it as well in COVID. In trauma, generally, we see RDS happening and the surfactant levels dropping because at some stage we've lost our blood pressure. And then we start using fluids to maintain that blood pressure. We give too much fluid and we start seeing that typical edema occur. And that's how generally adult or ARDS starts. In COVID, interestingly, we've seen a different pathophysiology to the ARDS developing. Mostly what they're seeing on postmortem are microemboli sitting along this capillary bed. And that is preventing the gaseous exchange. So it's very interesting that we have in trauma or where there's been where the patient's been shocked and develops ARDS, it's generally related to a fluid problem, too much fluid. But in COVID, we have seen this microclotting happening along here. Surfactant also acts as a barrier, so it's there to also prevent infection. The body will start producing its own surfactant at about 6 hours post-administration. So once that lung settles down and the baby settles down, now the baby starts producing its surfactant. Rest and sleep are essential post-administration. So now we are going to talk about the LISA method. And the LISA method stands for the less invasive surfactant administration. Now, the LISA method is something that originated in Germany out of Cologne. And what they have learned is that they don't need to have this vigorous intubation with a big tube, but they actually use rather small tubes, a very soft tube. They don't put it down straight into the lung, they just put it past the vocal cords into the trachea, and they get better, the babies actually respond to it better than generally trying to intubate. The LISA method is not a single technical procedure, but rather a complex care, bundle care, supporting the premature infant to adapt to extrauterine life. It's also known as the soft landing or the minimal handling way of doing surfactant. The LISA method, as I said, comes from Cologne in Germany, and it has been happening for the last 15 years and is now showing support across the globe. It is shown to reduce the need of mechanical ventilation and has improved outcomes for premature babies, especially avoiding BPD and intraventricular hemorrhage. So it's putting in the correct dose as quickly as possible. And it's a bundle of care. So CPAP has become the standard treatment for premature infants with respiratory distress. And this has saved many, many lives in the lower income countries, because a foundation like the Bill and Melinda Gates Foundation, who supported the development of Seattle PAP, have made it affordable for these babies to receive CPAP. Prenatal lung maturation with corticosteroids and good obstetric care is essential. So if that baby gets in at least one dose, but preferably 2 doses of corticosteroids via the mother, there is far less chance of severe respiratory distress developing. During the LISA method, it is important that spontaneous breathing is maintained throughout the procedure, and it should not take longer than 60 seconds in most cases. So this allows the baby to breathe for itself. In the more immature babies in Germany, surfactant is given within 20 minutes of birth, and it is seen as prophylaxis rather than rescue therapy. And this is becoming a trend now with right, that in the babies between 22 and 28 weeks, that the surfactant is actually given in the delivery room. The CPAP is placed in place, and the baby, as seen via Dr. Clark's lectures, given back to the mother while the surfactant is starting to work. And I know for a fact that the parents have given consent for the videos on that lecture, and it is very, very important, if you've got the time and the data, to please watch those lectures, because you will see the effect that this LISA method and returning the baby back is important. The LISA method also does not require sedation or analgesia, and in most instances, they only tuck the baby. So by tucking the baby, flexing the baby in, what you will see is that the baby actually takes to this method quite well. Also, at that stage in time, there's probably enough epinephrine or adrenaline on board that the pain factor is not actually that considerable if it's given within the 20 minutes. Caffeine is commenced immediately to prevent apnea and stimulate breathing in babies under 1,000 grams. This caffeine recently has come up controversially, that if it's given earlier, there's a higher chance of NEC. Not too sure about that, because if we can get colostrum in quick enough, it should prevent that. If the baby isn't crying, breathing, stabilize with mask and distending pressure. So start slowly and take it up. It's important that if you can, you use a system where you know how much pressure you are giving during the actual so-called bagging period. Oxygen no more than 30%, even in the preemies. CPAP can be given between 6 to 9 centimeters of water. The 6 is better for the smaller guys, but you can take it up, but 9 is sort of the limit. Most people will sort of say, wow, that's high, but they do use it in the bigger preemies. High flow nasal cannula is becoming more popular as well, and this method will work well if the positioning is correct. Spontaneous breathing is maintained through the procedure. The adaptation to extrauterine life is allowed for over 20 minutes. So there already you see that they are already pushing that envelope. Gentle stimulation, delayed cord clamping where possible, keeping the airway patent, avoiding unnecessary suctioning, maintaining the temperature, and avoiding any stress is very important. All of this can be done in the delivery suite, and the baby could go back to skin to stabilize utilizing oxytocin. So CPAP or continuous positive airway pressure saves many lives, especially in the lower and middle class countries. Severe respiratory distress syndrome, or RDS, is one of the 3 main causes of death in the neonatal period, and it's cost effective. It is the most cost effective way of treating RDS if you cannot afford surfactant. Even in South Africa, still surfactant is very, very expensive. CPAP in conjunction with antenatal steroids and early surfactant can reduce the work of breathing considerably and improve respiration and stabilization of the baby. So what does the CPAP look like? So this is a basic CPAP or the Seattle PAP. It's a non-invasive respiratory support system delivering a continuous positive pressure, keeping those alveoli open. It also splits the airway in the neonate, and it improves ventilation. CPAP is well suited for neonates as they are obligatory nose breathing, and maintain CPAP well because there's not an oral leak. Now, when you start looking at CPAP, it's very important, and I have put this article down here for you. This is a brand new article. It's also originated from the Nordic countries. And what it has looked at is it has looked at this interface here with the baby, and it's looked at this tubing here. And what it has found that is if this interface isn't correct, so we come back to that question of the CPAP mask against the baby's face. So if it causes a high resistance here, it's problematic. And if this tubing here isn't the correct diameter, it will also become problematic. The nice part about the Seattle PAP is this almost C-like curve here. So this is conventional bubble PAP. So this diameter is very important to create the bubbles. But with the Seattle PAP, and you can see it there, that curve actually improves the situation as well. So if you want to look at whether you've got the correct bubble PAP, so with the correct connections, please go and look at this article over here, because it talks about if these are too small, the resistance is high. And that can affect its exhalation, because remember, this is coming from the blender through the humidifier to the baby, and then it's exhaled that way. If this is wrong, you're going to get trapping of CO2. Oh, I don't know what happened there. Sorry, I didn't know that happened. Babies born under 30 weeks of gestation have a 60% chance of delivering RDS in developing countries, but it's higher in developing countries. It usually occurs within 6 hours of birth, and it's progressive. And the causes are a reduction in surfactant or insufficient production. Smaller alveoli do collapse and don't inflate again, and we have a reduced chest wall compliance. So now we come to what this is really about. What happens during ventilatory trauma? So what you will see here is that we start seeing this neutrophil and macrophage and these coagulant changes happening. because of what's happening with volume, baro, and atelectic trauma. So whatever we're putting in here, we start seeing this either infective or inflammation situation developing in the alveoli here. And that becomes a problem. So what we then will see is inflammatory mediators being released from there, which then leads to biotrauma. Now we will go through every one of these traumas in this lecture right now, but please remember that major surgery, excess fluid, sepsis and blood transfusions will aggravate the situation. And this is very important because very often when we are resuscitating babies because of a sepsis situation or because they've collapsed days after they have been admitted to the unit, that is no longer a newborn resus. That is a resus, generally a complex resus. And that is often where these sort of issues start coming into play. But it doesn't mean that you haven't had these happening. That it doesn't mean that this hasn't already happened, and now you've got these coming there. So you've got sepsis, or there's been a massive blood transfusion that's aggravated it, and now we start going towards biotrauma. This resus looks very different to the newborn resus. You don't have 10 minutes for this resus. This is usually a vigorous resus and quite fast, and its causes are multifactorial. So what is barotrauma referred to? This is the trauma which is caused by increased airway pressure during ventilation to the lung. And it is therefore when we use too much pressure. This is when you are bagging a baby, so using a bag valve mask resuscitator, you actually using increased or too much pressure, too high flow, and what you're starting to see is that you are starting to do barotrauma. So from the mediastinum, we start seeing emphysema, subcutaneous and mediastinum. In the pleural cavity, we could see a pneumothorax, and we can even cause a gas embolus because we are putting too much pressure on them. This is the pressure that firstly occurs a lot. And we must please be very careful. A rule of thumb is every finger that you put on that bag valve mask resuscitator is 10 centimeters of water. It is therefore better to use the so-called resuscitators on the resuscitators, if that makes sense. Volutrauma. Volutrauma is referred to local overdistension of normal alveoli. And this is why we basically use this rule of thumb of milliliters per kilogram. It is very important to remember that the harder you squeeze, the bigger volume you put in there. Remember that very early on in the lecture, we spoke about how many mils a lung can actually take. So you've got to be very careful with that. Barotrauma is extra alveoli air, and this can include a pneumothorax, pneumomediastinum, a pneumoperitoneum, and subcutaneous emphysema. And we see this often in these children. Often there is a pneumothorax, and when we get to morbidity and mortality meetings, it is not always discussed, and it should be discussed. So now you can see what these lungs look like. This is a normal lung. This is after 5 minutes, and this is after 20 minutes. Look how much larger, congested, and how much edema is in these lungs. Volutrauma, on the other hand, is lung trauma secondary to overdistension. So you cause this barotrauma, and then you get volutrauma because of the overdistension here. Volume trauma occurs when the individual units have overstretched and they start this bleeding. And how do you know this? This is often when you start getting pink secretions coming up. Biotrauma. So biotrauma refers to this inflammatory process, and it then starts landing in the main bloodstream and it starts affecting the other organs. The most common organ to be affected here that you will see is the kidney. So these babies don't produce enough urine, and now we start all these funny tricks of trying dopamine to drive a kidney. That's often due to this inflammatory mediator problem that has arisen. Also, unbeknown to us, there will be a liver involvement, and very often the brain as well can be involved in this situation. Atelectotrauma, which is something that we don't often discuss, but we cause, is this injury that occurs because of the shearing, so the bagging in and out, and we start seeing little tears all along here. And this can also happen as we increase the mechanical ventilation. And this is also because the alveoli are now starting to push against one another as well. So you see that anything where there's shearing, if you were to blow up two balloons as simultaneously, you'd hear that. That is shearing trauma. Now, lung perfusion is very, very important. And in about 2002, 2003, there was this big movement worldwide that we started looking at prone ventilation. It is now become, it's modernized now because of COVID, because now even if they come into the hospital and we place these adults, mostly adults, on CPAP, we ask them to lie on their tummies. And the reason for that is that you get far better lung perfusion when the lung is prone. Now, this study started off in the early 90s, was perfected in the early 2000s, when they started scanning firstly beagle dogs and then later on humans that were placed prone, and they saw that there was far better lung perfusion or VQ matching when the patient was lying prone. And for this reason, it is actually suggested to turn the baby prone once you've given the surfactant. So in pulmonary perfusion, there is more homogeneous distribution and alveolar distension when we place the patient prone. The biggest problem with the patient lying on their back is that the upper lung fields start collapsing. Whereas if we turn them prone, we start seeing this much better lung distribution happening. So with that, we have to talk about ventilatory perfusion and ventilatory perfusion mismatching. And this becomes quite important because if there's two components to ventilatory perfusion, and it's how we utilize it. So the first part is the V, or the volume of oxygen breathed in or given, and move to the alveoli where gaseous exchange comes in. So it's this here that comes in. The next is the perfusion or the blood flow. So once again, we come to this whole thing. Is this alveoli distended to its optimal level, not over distended or under distended? And is there a chance of it getting to utilizing the capillary bed so that the blood can happen, the exchange can happen? Now, there are two problems here. The one is that we need decent perfusion and not over distension. And the other is that we need the blood pressure here, maintaining the blood pressure. If this blood pressure is too high, that's what you will see. If this blood pressure is too low, this is what you will see. So you want this normal VQ match of 0.8, and I'll explain to you how that happens now. So you need both the perfusion part of the blood as well as the oxygenation. This dynamic interplay between breathing and cardiac output allows for gaseous exchange, and together with that, so you need O2 and glucose for cells to stay alive, for you to stay alive. So you need oxygen and oxygen landing in the blood. So oxygen getting to the blood, and you need glucose, sufficient glucose, not too much, and you'll need insulin if there's lots of glucose in the circulatory volume, but it can't enter the cells. So when you've got hyperglycemia, you're going to need to tickle with insulin to get the glucose from here into the cell, and oxygen will go as well. So mismatch happens when either the oxygen flow or the blood flow is affected. During a VQ mismatch, the problem is either mechanical, bringing it in, or physiological. So the mechanical causes are increased pressure or volume, or increased dead space. This one is quite easy to identify in the infant when you are ventilating, and we're talking here about a ventilator. Often when you disconnect this child, suddenly the saturations will improve. Then you know that the volume you're giving or the pressure you're giving is too much. And this actually happens fairly frequently, and people don't pick it up when they disconnect the baby and reconnect. Physiological causes could be pneumonia, could be BPD, so this lung being damaged, bronchitis, pulmonary edema, which is, you understand now, pulmonary embolus, or an airway obstruction. So if there is inadequate ventilation and or gaseous exchange, you'll get hypoxic vasoconstriction. And what this means is in the lung, the blood will be shunted to the areas that are expanding, where the alveoli are working. However, the blood's going there, but the blood can only carry so much oxygen. You cannot increase the absorption on the HB molecule for the oxygen, and therefore you will have a lowered PO2 reading. So now, how do we nurse this baby? How do we take care of this baby? What do we see hemodynamically? When we talk about the heart rate, as the RDS worsens, the baby's heart rate, the tachypnea, will go up because it's trying to improve its stroke volume to get more blood in the lung. But if you recall the first lecture about hemodynamics, the baby has an inability to create stroke volume. This is going to use up your reserve if you're not careful. Once the surfactant has been given, the tachycardia may still be present because the baby is trying to cope with that transient hypotension. Generally, they just need to be left alone and not fiddled and touched with, and not 500 procedures being done once the surfactant has been given. They just need to be given 30 to 60 minutes just to get themselves towards themselves. The respiratory rate, as the RDS worsens, the baby is more tachypneic and may start to grunt or push its PEEP, as I said, that sound, to improve gaseous exchange. Once the surfactant is in, the situation is more than likely to resolve, and there will be good lung compliance. So now your peak pressures become a problem. That is why we have moved away from so-called pressure ventilation towards volume ventilation. Blood pressures Prior to the administration of surfactant, the blood pressure will likely hold, although the mean may drop. Remember that whole discussion about mean blood pressures? But once you've administered it, there is likely to be a drop even in the mean blood pressure because of the increased circulatory surface. And a fluid bolus may be needed if it is necessary, but just give the baby time. Saturations, try and measure the saturations on the right arm. Remember we said that talks about preductally, and it gives us a better idea of perfusion to the organs and therefore tissue perfusion. Once surfactant has been administered, weaning of the oxygen may need to be rapid because that lung's opening up. Don't leave that saturation level sitting at 100. General medical care. So we do have to ensure that we do a septic workup in these babies, that there's IV therapy, that antibiotics, antifungals or antivirals may be necessary. And please remember that if antivirals, especially in the HIV situation, it needs to be administered within a short period of time after birth. Careful monitoring is important and nutritional needs need to be met. Nutritional needs are very important. We go back to this whole discussion of low protein. Low protein is going to give you pulmonary edema quicker. A baby that is malnourished is going to be at risk. It is often neglected. The baby becomes catabolic very easily and very quickly and will continue to lose weight. Their protein needs are high to fight the anti-inflammatory process which is occurring, and their fluid losses may also be high. And also be aware that reflux could be problematic here. This is partly why the latest research talks about TPN, so total parental nutrition, started within 6 hours of the baby being born, is to support the lung to allow it to actually regenerate and get better quicker. Hemodynamics, the glucose level is likely to initially rise to cope with the stress of breathing. Also, it is the cortisol effect. Cortisol will stimulate the release of glucose. So these children often run a higher glucose than rather a lower glucose. Once surfactant has been given and the baby is stable, we must consider buccal feeding colostrum, allowing for the adjustment to occur. This happens with when the baby is resting and self-soothing or non-nutritive sucking. Why do we give colostrum early? Colostrum has shown to actually help the lung and help the brain early on. And if we can get that colostrum as quickly as possible, if we feed small doses, even 0.5 of a ml, even 0.1 of a ml starts doing the work. It starts, you can put it in the oral cavity, it's absorbed there via the lymphatics, it moves across the blood-brain barrier, and it starts giving total protection from the back of the throat all the way down the GIT. Although oral colostrum did not modify the salivary peptides we examined, nor overall the oral bacteria diversity and composition, the infants that received OCP had a significant reduced length of stay in hospitalization, which hasn't been described before. Given the safety and the availability of this simple intervention, a reduction in length of stay warrants further examination. This is talking about buccal feeding or oral colostrum being put in the mouth. The act of sucking may also enhance bonding between mothers and newborn infants and the infants attached to the mother. I'm not saying that these babies that have just received surfactant, or well, if they're on nasal cannula, they can go skin to skin immediately, as well as if they're on CPAP in the delivery suite, or they are ventilated and the staff are good with, they are sufficiently experienced in it, even a ventilated baby can be left with the parent. In support of this, newborn lambs that are allowed to suck on the udder as soon after birth recognize and follow their mothers more quickly than those separated at birth. It's very important that you understand that attachment occurs with eye contact. And if these mothers get that initial cuddle with the babies regulate easier, even if the mother doesn't get to hold them again for 4 or 5 weeks. That baby has had that stimulation of the mirror neurons. It seems that neural reflex is induced from the oral mucosa by touching the nipple. And also the presence of colostrum in the gastrointestinal tract are involved in the creation of this primitive attachment. This is very important, this part of developmental care. So we talk about cluster care. Cluster care is when we deal with the baby once. If it's a very small baby, a micropreemie of 22 weeks to about 28 weeks, I prefer them only to be handled every 6 hours because that allows the baby to settle down. And I also try and teach the staff to know when the baby is awake and to handle it. So cluster care includes mouth care, and buccal feeding is mouth care. Skin care, routine strapping. So don't, because you walk past a bed, ask a nurse to restrap a baby because that's what you want done right now. It has to be done within cluster care. It must all be done together so that these babies are handled as minimally as possible. Bloods, x-rays, and blood gases should be done at this time as well, because there's constant moving, doing blood gases, and then doing an x-ray, and then deciding that you're going to change the nappy or position the baby, and then you're doing this. It all leads to overstimulation of this baby, and the baby cannot build its reserve. The care needs to be planned and done as fast and economically as possible. This will allow for better stabilization and conservation of oxygen and energy. And it does not need to happen every 3 hours. We have to come away of this thing that I haven't done my job if I haven't fiddled with this baby. We should not be fiddling with these babies. It's very important that we plan it and that we do it. And very often you should be asking your neonatal buddy to help you. That way, the quicker that you work with the baby and the more you cup and flex the baby, that also helps settle the baby. So, therefore, we are at the end of this lecture. I don't see why it hasn't pulled in. I had 3 apps which I wanted you to look at. The first was a decibel app, which you can load down onto your phone, which could measure the noise in your unit. The second app was the light meter that is available in both Play Store and Apple Store, and all of these are in Play Store and Apple Store, which allows for you to see how much light is in your unit and are you overusing light. And the third app that has come to play is a new app that has just been released out of Egypt and is very, very interesting, called Growth Calc, which is a growth chart application where you can load the babies in your unit on it and track their growth properly. And it also gives you syndromic growth charts, which means things like George or Prader-Willi or Down syndrome babies can be tracked on appropriate growth charts. It also uses the male and female preemie growth charts, which gives us far better growth. And remember, growth is an essential part of what we're doing. And yeah, that's us done.
Excellent, Linda. Thank you so much for this great lecture. I made a lot of notes because I thought it was quite interesting, the amount of detail that you have provided for all the different types of the lung diseases and potentially lung traumas. So now we're going to have another session of questions and answers. And we already have a few questions that came in the past half an hour. And if you do have any questions, please type them into your question box. It is on the right side of the of your panel, of your GoToWebinar panel. So, Linda, the first question: from the anatomy of the baby, which chest position is favorable and safe for CPR?
So it is the two-finger method for CPR that carries, that shows that it is better. Remember that what you're trying to do is that you are physically emptying the lung and emptying the heart by pushing down. And when you lift your fingers, what will happen is that there's it's not a can't think of the word now, but it automatically, the heart and the lung will fill with air and blood because you've taken your fingers off. There's this sucking motion that occurs, air goes into the airway again, and the heart fills with blood. So the two-finger method is at the moment in neonatology being shown to be more effective.
Thank you so much, Linda. That is excellent. Another question is on the administration of LISA. During LISA administration at labor room, what mode of ventilation do you support to provide the standing pressure? What ventilator device do you use?
So in the LISA method, they're talking that they are basically giving it within 60 seconds. And it is a very narrow catheter that is given. It's almost similar to the type of catheters we use for cannulation for IV therapy. So the baby actually can do its own respiration. Post that, a lot of people are now placing nasal cannula, or they are using CPAP.
Perfect. Thank you for that. The next question: in a preterm baby with severe RDS, which ventilator mode is effective or will deliver good and quicker results?
So that's almost a question for you, because for me, you know, volume ventilation is far better than pressure ventilation at this stage. But if it's a severe RDS and it arrives in your unit because it's been transferred, often the doctors will look at oscillation as well. Well, in South Africa, at least they will. But I think, Marguerite, your input would be great too.
Sure, yes. I mean, I completely agree that it depends on the severity of the RDS and the baby condition, and I would definitely opt for a volume targeted ventilation. And in the modern ventilators, there is the possibility to have pressure limited volume targeted ventilation or volume guaranteed ventilation. With this ventilation mode, we can really minimize the risk of the volume trauma, because we can clearly, we can precisely monitor the tidal volumes that are being delivered to the patients. And in the Dräger ventilators, which we will be covering in the next session on June 9th, I will be demonstrating a ventilation adjunct mode, which is called volume guarantee, which delivers the tidal volume at a minimum pressure that is required. So we are targeting the volume, obviously, and thus avoiding the volume trauma. But we are also delivering tidal volume at the lowest possible pressure, thus limiting or reducing the baro trauma. And Linda, when you were talking, I actually also had to think that if it's really a severe case of RDS, I would also opt for the high frequency ventilation because it is, according to the research, it proved to be more safe and it offers better oxygenation and better recruitment, so to say, when the case of RDS is really extreme. However, I do understand that high frequency might be considered as an advanced option and not everyone would have access for it. But if you do have access to high frequency oscillators of any sort, I would probably opt for an HFO. And of course, in our ventilators, we also offer the volume guarantee in HFO, so we can really customize the volume target for each patient, and we can really make the high frequency ventilation safe. And in the next lecture, which we're going to have on June 9th, we are going to be covering the basics of mechanical ventilation, and I will be doing the hands-on demonstration on a baby log ventilator. So if you have the time, if you're available, please join for that lecture, because there we will be really focusing on the mechanical ventilation.
Also, Marguerite, just to say that when you have normal ventilation, so like you and I at the moment, actually breathing in is a passive phase, where breathing out is an active phase. When you ventilate, breathing in is the active phase, breathing out is a passive phase, so it turns it on its head. When you look at HFO, it's very interesting because it's then an active phase, which means that the expiration and in HFO, there is a certain amount of exhalation that is done by the system. So it's very important just to keep that in the back of your mind, that when you start ventilating, you reverse the actual natural way of breathing. So breathing in is passive, breathing out is active. So when you resuscitate and you push down on the lung, you are pushing out and the air will flow in. That's an active phase.
Excellent. Thank you, Linda, for this comment. Yes, that's definitely a big difference of mechanical ventilation. But I think we'll be covering more of this in our next lecture on June 9th. So the next question, will the condition of respiratory distress syndrome be improved if mother received 2 doses of dexamethasone at 24 hours and 2 hours before childbirth?
Yes, the research clearly shows that that has been a major game changer. Years ago, we didn't give dexamethasone, and the babies had severe RDS quite quickly post-delivery. Now it is much better. So yes, it has been shown to work.
Excellent, thank you. Okay, the next question, are there any benefits of the number of steroids given antenatally, 1, 2, or 3?
The research shows that 2 is beneficial, you know, but there are doctors that are giving up to 3 doses. But by the 2nd dose, that baby already is reaping the benefits.
Perfect, thank you. There's a very interesting question, I think on the case from one of the nurses or a doctor. Baby with meconium liquor, meconium aspiration, did not undergo the SCN observation. Mother went home at 6 hours post-birth, came back to ED due to apneic and dusky breathing, and have seizures events. What is the main cause? Is it RDS? Is it septic? What would be the explanation of this?
So there could be, because remember that meconium aspiration causes a pneumonitis, which will cause a reduced PO2, but also very often with meconium aspiration, we must remember that there could be a traumatic birth. So the seizures may indicate an element of HIE or hypoxic ischemic encephalopathy, and sepsis could play a role. So all three are likely, but my money would be that very often, well, my experience based on mostly in South Africa and Africa is that meconium aspiration occurs in big babies, and very often there is a hypoxic ischemic event that goes with it, which will lead to seizures. But I mean, that would be where what I would look at. But unless we look at the case per se, we can't really say.
Great, thank you so much for your input on this. I think it's quite interesting to see real cases, real examples, because that's what basically happened with babies, and that's the real case problems that we would like to address during this module, during this course as well. So thank you for this question, and thank you, Linda, for giving your opinion on this. So far, we have not had any further questions. So if there are no more questions, we are going to switch to the hands-on demonstration. And today I will be doing a demonstration on the Seattle PAP system, the Bubble CPAP system that Linda has also referred in her lecture. So welcome everyone again, and as I mentioned, today we will be talking about the Seattle PAP Bubble CPAP system from Dräger. I think I have to say a few words about the system. The Seattle PAP has been developed by the Melinda and Bill Gates Foundation, and we have partnered with them to distribute and to further develop and improve this product. So we're quite happy about it because we know that the main goals of the Melinda and Bill Gates Foundation is to support the developing countries, and we as a company, we also want to support the developing countries with the technology that is easy to use and that requires very limited resources. So as I mentioned, this is the overall standalone solution for Bubble CPAP, for delivery of the Bubble CPAP therapy. So here we have it positioned on the trolley, but we can also, of course, put it on the side of the incubator, on the side of the open care warmer. It can also be mounted on the wall. So there are different possibilities for the mounting of the system. It consists of a few parts. However, we know that a lot of hospitals might not necessarily have the standalone oxymixer or the oxygen blender. This system can also work from the 100% oxygen from the wall supply, or if there is a gas outlet with the pressure reducer, can also work from the wall connection. So as a part of the system, as a standalone, we have the oxygen concentrator, oxygen mixer. So this can change the oxygen concentration from 21% to 100%. However, as Linda has mentioned, I think we have to be very careful with the delivery of 100% of oxygen, because it might have a rather detrimental effect on the babies especially we know that there are certain conditions associated with the higher percent of oxygen, such as retinopathy or prematurity, and we have to be careful when selecting the oxygen mix. So I think Linda, you can mention, but we would consider starting the resuscitation, and I think we covered this topic during the last lecture in resuscitation, that we would rather start the lower oxygen concentration, about 30%, and then see how the baby responds to this. So the similar would apply to the Seattle Bubble CPAP system. We just have to be quite careful on the oxygen FiO2 settings. So also we have 2 flow meters here. We also have the possibility to have just 1 flow meter, so depending on what kind of flows you are used to working with, we have the low flow meter, so this goes 0 to 3 liters per minute, and then we have the higher flow meter, so that goes from 0 to 15 liters per minute. And obviously you have the control knob that help us to set up the right flow. So we just can increase the flow by turning the rotary knob. The better view. Yes, so that what I was saying, this is the oxygen concentrator, and then we have the low flow meter, 0 to 3 liters per minute, and then we have the high flow, 0 to 15 liters per minute. And then if we actually scroll down to the actual Bubble CPAP system, I'm just gonna put the camera down. So this is our CPAP system. This is the Seattle Bubble CPAP system, and we can see here. So we have the tube that is responsible for the control of the CPAP setting or the PIP setting, and the good advantage or the advantage of Seattle PAP is that this PIP setting is actually protected by the safety valve. So normally, if we look at some of the other systems, it is quite easy to accidentally change the PIP setting because this tubes are not protected. And we saw that especially in an environment where we have a lot of equipment surrounding the baby, we have to have safety precautionary mechanisms. And that's why we have the safety valve. So in order to change the CPAP level, we can move the safety valve, and then we can either reduce the CPAP, and you already see that the bubbles oscillation is a bit less, or we can reduce the CPAP, or we can increase the CPAP to the maximum, and we see that the bubbling is now more vigorous. Also, I think it's important to say about the concept of the Bubble CPAP. So, as Linda has mentioned in her slides, CPAP machine for CPAP equipment is basically generating a stable level of continuous pressure that prevents, by maintaining the same pressure, prevents the alveoli from the collapse. So, and the Bubble CPAP in particular generates this pressure by bubbling of the water, and thus creating a certain level of oscillation. And I think Linda has also mentioned in her lecture that in the normal bubble pump system, usually you have just a 90-degree tube that generates these bubbles. In the Seattle PAP, you have the 135-degree angle. And if you look at the comparative studies from Seattle Hospital, we see that this angle returns better oscillation, which translates to better respiratory support for the neonates. So, I mean, this system is extremely simple. So all you need to have is, of course, the humidifier. I mean, talk about the importance of delivering humidified and warmed air because of the immaturity of the respiratory system of the neonates and also potential damages that are associated with the ventilation with dry air. And I know that not many or not every hospital would have access to active humidification. However, I think it's important to emphasize the importance of delivering humidified air, humidified, saturated, warm air, in order to avoid the damage to the trachea and also to the damage to the mucociliary system of the baby. So we have the connection here to the humidifier. You can use any humidifier that is available in your hospital. We also have a safety valve. So this safety pressure valve is at 17 centimeters of water. So that means the pressure the pressure that is delivered to the baby will never exceed 17 millibar. Because we know that we're just trying to maintain a stable pressure. Of course, there are cases when the babies fight the system or they grunt or they cough, and the system have enough flexibility to allow the baby to do that, but we will never deliver excessive pressures to the baby. So that's why we have the safety valve that goes open at 17 when the pressure reaches higher than 17 millibar or centimeters of water. Also, if we look at the system, I mean, it's quite simple. We have the Bubble CPAP container, and then we have the message at which the water level needs to be filled in. So it's quite simple, and that is pretty much all of your connections. So I think it's important to say a few words about the breathing circuit that is being used during the CPAP system. So Linda has mentioned that on the inspiratory side, the circuit, it is important and it's better to have the circuit that is supporting the warming of the air. So here we have a heated inspiratory circuit. So this is the heated inspiratory circuit. We see that the heating elements, so this blue line, show you close proximity. So this blue line, the blue line of the circuit, this is actually the warming element. So we don't have any lines that go inside the circuit because we know that these lines, they can potentially increase the resistance in the circuit and they can also influence the effectiveness of the CPAP system or of the CPAP therapy. That's why we are using the circuit with the with the warming element that is located on the outside of the circuit. Also, Linda has mentioned that on the expiratory side, it is important to have a smooth bore circuit. And if we look at the setup here, we have a simple circuit. And considering that the expiratory circuit here is not humidified, it is also important to have the water trap. Because what we're going to experience is that we have the humidified air, warmed and humidified air, delivered to the patient, and when the patient exhales, the temperature difference between the exhaled air and the outside temperature in the medium will have an effect and will have a condensation effect in the expiratory circuit, in the expiratory limb. That's why it's very important to have the water trap, which is properly positioned. And I mean, vertically positioned, not in this manner, not in this manner where the water trap cannot collect the liquids. So the water trap needs to be positioned vertically to the ground so that the expiratory condensation can go into the water trap and not back to the patients. So, and this is with regards to the circuits. We also have the possibility to have a dual heated circuit. So we will have the inspiratory heated and expiratory heated, and in that case you would not need the water trap because the condensation will be reduced by having the heated expiratory circuits. I think it's also quite important to say a few words about the interface during the CPAP therapy. So Linda was mentioning, and we had this question as well about the sealing, the sealing of the mask onto the patient face, and that in neonates it is particularly difficult because of their not fully developed features, and also because the masks are not soft enough to fit in properly into the neonate's face. So here we have the baby flow solution that is specifically designed for the neonatal patients to deliver non-invasive therapy. So let me just demonstrate to you in a bit more details. So this is the mask made of silicone with this special positioning aid. So now, when we position the mask, we don't have to fit in very tightly. We can actually, if we do it too tightly, then there's going to be even the vacuum. But this this special design of the side of the masks allows for easier positioning of the mask without the exposing additional pressure on the baby face, and thus we can potentially avoid the pressure source and the damage to the nose of the patients. So again, we can see that this baby flow mask is actually made of very soft material, and the positioning is quite flexible. So even just a slight touch already offers a good seal, and even if the baby moves or the circuit moves, we still offer a good seal on the mask because of this accordion design, so to say. However, I do understand we have different sizes of masks, and we also have this guide on how to select the right size of the mask. So basically, you can measure, first of all, the nasal distance, the distance for the prongs, and you can select the right size, and you can also measure the area in order to find the right fitting size of the masks. We also, of course, have the possibility to have smaller masks, so we're not only offering the larger size mask, but we also have the smaller mask that also done in a similar design that offers good good positioning and good fitting of the mask. And also, of course, as an alternative, we are offering, this is also a mask, but we also have the possibility to have the nasal prongs. So the selection of the interface is quite variable, so it depends on what you feel more comfortable with, what the baby feels more comfortable with, and I think Linda has mentioned that the high flow nasal cannulas therapy might be more beneficial or at least more comfortable. So you have the possibility to start in the CPAP treatment to see, even in with the nasal prongs, to see if the baby can sustain the therapy, and then, if necessary, switch further to the high flow oxygen therapy or potentially if the baby condition still deteriorates, you have the possibility to switch into the invasive ventilation. So as I mentioned, basically, you don't really need to have the connection to the power. So the Bubble CPAP itself is independent from the power source. The only thing that you do need to have is the gas source. So it can be either a cylinder, it can be a wall supply, but basically that's something to drive the ventilation. Other than that, you can use this, if you have cylinder, you can use this system for transport. And we already saw in some instances where the babies are being delivered in labor and delivery, resuscitated, and then transported using the bubble CPAP into the NICU if the baby requires a little bit of post-resuscitation respiratory support. That's pretty much everything what I wanted to cover today, and I didn't want to go into the details of mechanical ventilation because I think in about 2 weeks on June 9th, we're gonna have a dedicated module around the mechanical ventilation, and I'm going to be demonstrating the ventilators and the options that are available in order to optimize the ventilation when the baby requires the intubation. So with that, I would like to thank you for your attention, and now we will open the floor for the final set of questions. If you do have any questions either on the lecture that has been covered today, or on the Bubble CPAP system, or on the clinical cases, please type them into the question box, and we would be happy to answer them. So far, let me just check. So far, we have not received any new questions. I'm gonna give it another few moments. And then I would like to highlight again that we're going to have a second module on the respiratory system on June 9th. So please register for that module, and we would be happy to talk about the further neonatal ventilation. Okay, so we have a few questions that came in. Okay, so the first question. Can you please repeat why we use Fetal CPAP and why the tube is at 135 degrees? Okay, so why do we use the Bubble CPAP? Bubble CPAP is used to generate continuous positive airway pressure. So that is what CPAP stands for. And basically, this is suitable for spontaneously breathing patients to maintain the alveolar pressure, so that at the end of expiration, the alveolar do not collapse. So the idea behind it is that we provide stable pressure to maintain the functional residual capacity of the babies and also prevent from atelectasis or from alveolar collapse on the expiration. And the reason why we are using the 135-degree angle is because there is research, and we would definitely include the link to the research in the slides. The research suggests, or basically according to this research, let me demonstrate that to you. According to the research, the 135-degree angle returns a better oscillation. So basically, Bubble CPAP generates this water oscillation and thus generates certain volumes. And they compared the volumes that are being delivered, because obviously in here we have no way to control the tire volume, because we don't have the flow sensor in any point, so we cannot control the tire volume. But they were doing this in a research setting, and they have discovered that the volume that is produced from the 135-degree angle tube is higher than the volume that is produced at the 90 degrees or the vertical tube, and thus providing better respiratory support to the babies when performing the Bubble CPAP therapy. Linda, do you want to add something on here in terms of the 135-degree angle?
No, only to say that that article that we referred to in the lectures, and we can give you the link to it, actually also supports what you've just said, Marguerite. It supports it.
Perfect. Thank you, Linda. Okay, I hope that answered your question. Okay, so the next question, can you explain the difference between the CPAP and the PEEP? Linda, would you like to do that, or shall I say a few words about it?
So I will start and you can take over. So CPAP is continuous positive airway pressure. So that's to keep the lung open. The PEEP, so peak expiration, PEEP expiratory expiration pressure has to do, we've all got PEEP. We've all got PEEP, and physiological PEEP is 5. By giving continuous, by giving CPAP, you're just supporting that PEEP and allowing for gaseous exchange, if that makes sense. So we all have PEEP. Most babies need a bit of help to support their PEEP, and that's what continuous, what CPAP does, is it maintains that PEEP and gives a bit more to just keep it open and allow for gaseous exchange.
Excellent, thank you, Linda. And I think we should refer back to what you said about mechanical ventilation. So you mentioned just a few moments ago that in the spontaneous breathing, the inspiration is active, so we actively inhale, and the expiration is passive. In the
Other way around.
Other way around. Yes, other way around. So in the mechanical ventilation, the inspiration is active. So the machine is pushing the air into the lung, and the expiration is passive. And the PEEP, this positive and expiratory pressure, is the pressure that prevents the alveoli from the collapse. So this is more of a, yes, you have the big setting on the machine, but there's also such thing as an intrinsic PEEP. So this is the pressure that is currently in the lung that is preventing the lung from collapsing. And CPAP, considering that it's a spontaneous mode of ventilation, we are trying to maintain the same type of pressure. And the idea is that the PEEP is going to be the same, but there's also the risk, if there is a challenges with exhalation, that the baby will develop an intrinsic PEEP, and the total PEEP might be higher than the CPAP. So that's like in general, during the CPAP therapy, you can say that CPAP is exactly the same as PEEP, but from the physiological perspective, there might be differences because of this intrinsic PEEP or the positive and expiratory pressure that is building up in the lung because of the challenges with expiration. Okay, I hope we answered that question. So the next question, how often do we need to change the water from the container? Linda, in the clinical practice, how often do you change the water?
So the water will need to be filled up. If you need to change that water, it should be changed every, remember it's humidified, so that already prevents problems. But it's heated, sorry. But generally, we would change the circuit, Margarita, every 7 to 10 days, because the risk is what is hibernating in the circuit. The water generally, it can, I mean, it's filled up, but generally, you've got to watch that water level because it evaporates.
I have to add the same. I mean, even from the recommendation perspective, from the reprocessing perspective, we have the guidelines in terms of how often does the circuit needs to be changed, and that's it's exactly 7 days. But when it comes to water, I think I will have to investigate this a little bit further, and I will get back to you on this topic.
Yes, and I'll also look at it. It's not a problem. We can give it in the recap section next time.
Yes, we will refer to it in the recap section next time. Yes, thank you, Linda. Okay, the next question. Okay, what is the name of the mask you talked about towards the end of the demo? Is it silicone-based? Is it commercially available as part of the accessories? Yes. So the name of the mask, and I can show it to you, it's called Baby Flow. So, and the Baby Flow, it is commercially available. It is available as a set, so you can order, and I can demonstrate to you. So you can order the mask, the headgear. It comes together with this measurement tape and the different sizes of the mask. So it is possible to order as a set, S and L sizes or XS, or also available as a standalone accessory. The mask is a silicone-based, and as I mentioned, it is a very soft material, BPA free, so there's no BPA in the mask, and also that supports the positioning. I mean, there is a few other things that I can talk about this mask, and this is in particular this head. Let me switch to the other view. So this head of the tubing. This head is actually rotatable. So you see here. So it can be at a 90%, at a 90-degree angle for the better positioning during the mask ventilation, but it can also be at 100 and I think 35 or 45-degree angle for the positioning of the nasal prongs, for the better positioning of the prongs. So you see here, this is the rotatable head of the circuit that allows for the better positioning of the mask. So if you leave us your details, our partner in your country will get in touch with you and we will provide the details of the mask availability in your country. Okay, I think the next question we already mentioned. How often do we need to change the ventilator circuit? And the circuit we already mentioned that the requirement to be changed every 7 days. So that is the factory default requirements. Okay, another very interesting question. How will you measure the accuracy of CPAP level delivered to the patient and bubble device set pressure? Linda, would you like to say something about it?
No, I think you must deal with it, Marguerite, because for me, the big thing is, what does the blood gas look like? What does the baby look like? Are we able to wean the baby? That would be important, and as you've explained how the whole system works.
I completely agree with you, and if I had to give this answer, I almost would say, well, you cannot, because this is a very simple system to generate the CPAP. If you want to be able to measure the CPAP and the tidal volumes that are delivered to the patients, and all of this quantitative parameters, in that case, you would need to use the high-end machine that has the pressure valves, that has the volume flow sensors, that has the monitoring possibilities, and that is then a lot more complex machine. Here we can really offer the CPAP therapy. I mean, we can only rely on the research that is available, and in the research setting, we saw that the delivery of the CPAP is very stable. It is stable throughout the time, and that's the only way how we can monitor from the quantitative parameters. But I completely agree with Linda that you always have to look at the baby. How is the baby saturation? How is the baby work of breathing? Is the baby struggling? Is the baby comfortable? Is the baby fighting the ventilator, or in this case, bubble CPAP? These are all the physiological characteristics that really give you enough information about the effectiveness of the therapy. And I think that's what we need to look in the first place, check baby condition before making any changes.
Also to mention, Marguerite, is that, you know, the high-end machines, you're looking at something called CPAP. It's no longer CPAP. And also to remember that this system frees up a machine for a baby that will benefit and require it. But my experience generally is that probably about 70% of babies in a unit can quite comfortably be on this unit, and which means that we could care for more babies because we don't have to buy those expensive machines to actually administer something that is, in research terms, shown to be very effective.
Excellent. Yes, thank you so much. Okay, so another question. Can you explain again the purpose of the blue cap container? So I suppose that you refer to this blue cap, and this is the safety valve. So, and that is probably referring back to the previous question, because there is no way to really measure the pressure in the system. There can be cases when for example, the circuit is kinked, or the mask or the interface gets blocked, for whatever reason, when the pressure is being built up in the system. And in order to avoid the build-up of excessive pressures, this is the so-called safety pressure valve. And whenever we reach 17 millibar in the system, this valve will get open to release the excessive pressure in order to avoid the build-up of the pressure and the delivery of the excessive pressure to the baby. So this is just a safety valve to avoid excessive pressures. Okay, so that is a very good question. Why the CPAP is shown on the Dräger ventilator is PEEP? That is indeed a good question, and this is basically the nomenclature. And at the end of the day, the CPAP is the therapy name, continuous positive airway pressure ventilation. This is the name of the ventilation mode, if you would like to. PEEP is the setting that you set on the ventilator and even on the bubble CPAP, positive and expiratory pressure. So the target, that PEEP, is exactly the same as your target for the CPAP during the CPAP therapy. But because of this physiological PEEP, the total PEEP might be different. But the idea behind it is that the PEEP that we set, the positive and expiratory pressure, this is the parameter that we set. This is the name of the parameter during the CPAP therapy, which is the continuous airway pressure support ventilation. So I think it's just a matter of the nomenclature. At the end of the day, the target is the same. We target PEEP during the CPAP, or we target the CPAP during the CPAP. But as I said, because of these physiological complications, we might experience that the total PEEP might be higher than the PEEP that you said. And that's why in our machines, we also have the possibility to measure the intrinsic PEEP and have the information about the total PEEP. Okay, so the next question is that bottle hangs on the drip stand part of the CPAP setting? If yes, what is the content in the bottle? It is actually not, and I think that is the question that is being asked. So this bottle in the drip stand, this is not part of the of your bubble CPAP solution. This is just the water that goes into the humidifier. So in order to ensure that, obviously, because during therapy, the water in the humidifier will evaporate, and in order to have the continuous delivery of the water into the humidification compartments, we have this water drip bag. So this this can be your normal distilled water that is delivered into the humidification compartments for offering the humidity. So this is not part of the setup of the bubble CPAP. Okay, so that is an excellent question. What is the recommended flow to deliver level of CPAP on this device? Linda, maybe you can say a few words about the general settings of the flow during the CPAP therapy.
The flow?
Yes, the flow. How would you set the flow during the CPAP therapy?
So generally, the flow that will be required is usually run sort of between, sure. I'm not sure on that system, but generally it runs between 5 and 8.
And similarly, in the bubble CPAP, we also do the recommendation, and I think it's regardless whether it's bubble CPAP or any other CPAP system, but the general between 6 to 8 or 5 to 8 liters per minute. I would agree with that.
Yeah, and that's why high flow nasal cannula also starting to take over a bit in that field, because we also run that between 5 and 8.
Yes. Thank you, Linda. Okay, so the next question, do you recommend the bacterial filter in this ventilator for infectious cases? If yes, what is the appropriate part to install the bacterial filter? Well, to be really honest, and I think, Linda, you can also share your clinical experience, but we do not tend to use the filters on the extremely preterm infants because of the increased resistance and as a result increased work of breathing. And I mean, it depends on what kind of solution you have, but this can come in a single use. So this setup is a single use, so you can just put it on the patient and discard after the use. We also offer the reusable circuits, which can be cleaned after each patient use. But in terms of the use of the bacterial filter during the CPAP therapy, I don't think it's a common practice, to be honest. Linda, in your unit, have you used the bacterial filters?
No, not at all. And in actual fact, there is a lot of research going on regarding the appropriateness of a filter for short term. The idea with the LISA method and the CPAP is to try and get the baby off the oxygen as quickly as possible. And a lot of babies are coming off within 48 hours to 72 hours, and there's no need then for a filter. So we don't use filters in South Africa, very rarely. We change the circuit though, every 7 days.
That's what I would also see in other countries, that even in the developed markets, in like UAE, Kuwait, Saudi Arabia, I have not seen the use of filters in the neonates, and particularly in the preterm neonates. So yeah. Okay, and I think the final question that we have, how oscillation from CPAP that we talked about can help the patients? And the kit valve, what is the correct position for it? Is it always open or closed? So during the normal operation, the valve is always closed. So it comes, and I'm gonna do, there might be sound, but it comes basically as a setup like this. So I can show it to you very detailed. So it comes as a setup. You don't open it or you don't close it. You just connect it to the humidifier here, and then you don't touch it. And then in case if the pressure in the system is built up, the valve will pop itself. So it will open itself in order to release the pressure. And then it will close back to once the pressure goes down. With regards to the oscillation, I think I've mentioned this already, and I think what we're going to do, we're going to include a slide with a link to the article. Basically, this oscillation, it generates volume. And this volume is obviously the volume that is being delivered to the patient. So at the end of the day, the main target of the ventilation, and I think Linda has addressed it in a lot of details in her lectures, is the gas exchange, appropriate gas exchange. And the way gas exchange happens is the oxygenated air from the ventilator or from the bubble CPAP system is delivered to the patient. So the air that is saturated with oxygen. And then this air reaches the alveoli. And if there is a correct perfusion, then this oxygen from the alveolus goes into the blood, and then this blood flows through the body and oxygenates the entire body. So, and in order to ensure appropriate oxygenation, we want to have appropriate delivery of the tidal volume. And with this oscillation that this water generates, we produce certain amount of volume. And the research has demonstrated, and that's why it's so important to have the angle at 135 degrees, because the volume that is generated from this oscillation is higher than the volume is generated from the 90-degree tube that we have in some other bubble CPAP systems. And that's why we have more effective ventilation with this more effective oscillation that is coming from the bubble CPAP. Linda, would you like to add anything here?
No, I think you've explained it perfectly, and it explains why the system has been made that way and what the research is bearing out.
Okay, so there is a question. Could you demonstrate how to top up water into the white container? And that is an excellent question. Let me just move the system a little bit further. I'll move the camera up a little so you could see it a little bit better. But it's actually very simple. So what you need to do, you take, I mean, obviously I'm using this bottle of water, but you would use your water that's available in your system, in your hospital. So what you do, you just remove the expiratory limb and you add the water through the top tube. You could also, through the top tube. Yeah, so it's quite simple. I mean, I don't have too much because then we will exceed the desired limit, but it's actually quite simple to add the water. Okay, another very interesting question. Is there a connection if patient needs NO therapy while patient is in that system? I mean, the answer is no. There is no possibility to connect the NO therapy device integrated. Of course, you can use it as a standalone solution. And you could deliver the NO gas as a standalone if you have the NO therapy machine, but it is better to deliver the NO therapy if it's connected to a ventilator, like for example, baby lock, because you have the information about the minute volume from the baby lock, and therefore the delivery of the NO gas is more is calculated based on that minute volume. In this system, we have no possibility to really measure or control the minute volume because the patient is breathing spontaneously. And of course, you can deliver NO therapy, but you would not have the information how much minute volume is in the system, so you might not have the control over the use of your NO therapy. So I don't think that in this setup you would opt for an NO therapy solution. Linda, would you like to add anything on the NO integration here?
I really don't think that nitric oxide warrants to be given in any CPAP situation, because it's not an active ventilatory method. It remains a passive ventilatory method. So, I mean, I really don't understand that, and perhaps it's in a very advanced unit, but we would not give NO in a CPAP situation. The patient's usually weaned off it by the time we get there.
Perfect. Thank you so much, Linda. And with that, I think we would like to close the session. And we would like to thank you all for being with us today, for listening to the wonderful lecture that Linda has presented today, and also looking at the demonstration of the CPAP. If you have further interest, please visit our website and register for the upcoming webinars. The next webinar is going to be on the respiratory system and mechanical ventilation with the ventilators. It is on June 9th, and for the details, you can follow our website on the Neonatal Nursing Course. And Linda, I would like to thank you for this excellent presentation, excellent questions and answers. And I look forward to welcome you all back on June 9th, and have a great day, everyone. Thank you and goodbye.